I want to discuss the most important part of knee replacement, and that's ligament balance. Historically, knee replacements have about an 80% satisfaction rate, which means 20% of people were not happy with the result. That doesn't mean they were unhappy, it just means they weren't fully satisfied. Now, over the years, we've done things to try to improve those numbers, but we're still not where we want to be. A big step forward in improving knee replacement outcomes has been robotic technology with the precision and accuracy that we can put these knees in. Are we perfect yet? No, but we're coming a whole lot closer. So today we're going to discuss ligament balancing, all right? So we're going to start out with a Varus knee. This right here is an AP x-ray of a Varus knee. It's worn out on the inside. It's loose on the outside. So what we expect is the MCL, the medial collateral ligament, we expect to be tight medially, and we expect the LCL, the lateral collateral ligament, to be loose laterally. And we expect that when the knee is straight and when the knee is bent. This is a lateral view just looking at it, all right? So we can get rid of these just to declutter. Now I want to look at these two screens here, all right? Because this is the crux of the robot right here. And you have to understand these screens before we get into the details. This is the screen on which we're going to tension our ligaments. So this graph right here, that line across is neutral, all right? That's 0, all right? If a ligament is tight, the bar will be below. If a ligament's loose, there'll be a bar that's above. And we test the knee at both 0 or near extension, full extension when the leg's straight, and past 90 degrees when the knee's bent. We want to find out where it is in both locations. And then if we balance the knee when it's straight and when it's bent, it will be balanced all throughout range of motion, all right? So we'll test it here and here. Now, you see the orange and the purple. So orange is medial, all right? That's the inside, your MCL. That's testing the MCL tension. The lateral is the outside of the knee. It's your lateral collateral ligament, and we'll test that, all right? This is the planning screen. So once we've obtained our robotic data, we'll come over to the planning screen. And the planning screen is this data right here, and then added on to that, it allows us to change our implant position to balance the knee. See, because traditionally in knee replacement, what we would do is just put the knee replacement where we wanted it, and then cut the ligaments just enough to make it work. And while that gave us x-rays that looked great, it gave us patient satisfaction scores that were below what we wanted. That was that 20% of patients that weren't satisfied. And so what we've done is gone to this kinematic knee replacement, okay? This patient started out with 2 degrees of Varus. We're probably not going to end up at 0 degrees. So our post-op alignment is not going to be 0 at the end. It's going to be something else. So our range of motion, so -1, that means this patient hyperextends by 1 degree. Is that a big deal? No, not at all. That's so close to 0, you can't tell that. And it goes to 98 degrees, which actually is not very good motion. We want a post-op knee to get to 120, and a normal knee, like when you're 20 years old, don't have any deformity, that should be like 140 degrees. So a post-op total knee, if we get to 120, is great, but when a patient doesn't have great motion beforehand, it can lead to them not having great motion afterwards, but we're still going to improve this. So this screen shows you extension down here and flexion here, okay? So extension when the knee is straight, it's showing that the medial side has 0.8 millimeters of gapping, and the lateral side 1.6, a little bit more. And that actually looks pretty good. You see, we want the knee to be a little bit tighter medially than laterally in order to drive the knee kinematics, in order to drive that medial pivot knee. But in flexion in this knee, the medial side is loose, okay? So the medial side has the larger bar with a 5.4 millimeter gap and a 3 millimeter gap laterally, okay? So what I can do is change the implant position, all right? So I can change our tibia. I can change the Varus and Valgus. I can also change the slope. So the knee slope, if you look at the tibia here, I can put more slope in it like that, and it'll actually open up our flexion space. So I can change the tibia in all planes. I can also resect more bone. If we're tight everywhere, I can resect more tibia bone and loosen things up. I can also resect femur bone. If I resect femur bone, it'll just loosen us up in extension. On the femur side, I can change the femoral size, all right? Changing the tibial size doesn't change your balance, but if you change your femur size, it'll tighten things up. If I change the femur rotation, either internal or external, it'll change our ligament balance. So that's the fine tuning I have to do, and that's what takes a lot of schooling to understand, so it's a little bit above our heads, but I wanted to at least explain this before we get into the video. So let's bring this video here, and let's make this, ultra high def, so we can kind of sit back and watch it. All right? So this is us balancing a Varus knee, okay? So this is the x-ray. This is what we expect. It's going to be tight on the inside, loose on the outside. This is a lateral x-ray here. And now we're going to collect the graph. So we see tight medially, and when we do test the gap in flexion, we're going to find a surprise. Loose medially. All right, that's not what you expect on a Varus knee, but not everyone behaves normally. So what I'm going to do is actually re-stress it, because anytime we find something we don't expect, we always want to double check and verify, because we want precision in surgery. So I double check it and the bars look the same. We were right on. So now we're going to go to that next screen, the screen I already showed you. All right, and here we are. So I'm going to tinker with everything. I'm going to tinker with the position. I'm going to tinker with the femur size, with our rotation, with our varus valgus, and we're going to end up exactly where we want. You saw there, I just jumped up a femur size, and that brought our flexion gap down. And we're going to end up right here. And I love this, okay? We've got just over 1 millimeter of space of gapping laterally on both flexion and extension, and we've got very little gapping medially. So that's going to drive that kinematic knee, that medial pivot knee, keep it tighter medially so that it can pivot laterally. So this is exactly what we want on a Varus knee. All right, so now I want to show you how to balance a valgus knee. This is a standard valgus knee where the outside of the knee is tight. Typically in a valgus knee, the lateral femoral condyle loses some bone and this person becomes knock-kneed. So the lateral collateral ligament on the outside should be tight. So our purple bar should be smaller. And our MCL, or medial collateral ligament, should be looser. That's what you typically see in a valgus knee. This is a lateral radiograph, all right? So let's get rid of these. Let's bring our Corey screen in. Let's make it high def, and let's watch this together and see what happens. So this is planning a knock-kneed valgus knee. Again, these are our x-rays, right? Tight laterally, loose medially. That same lateral x-ray. So let's see how we plan. So medial side, looser in extension. Let's see what ends up being in flexion. So now here we go. So looser medially, but not quite as loose, right? So in extension, the medial side is really loose compared to laterally, and we're a little bit closer. So now again, I'm going to change the varus valgus. I'm going to change the implant rotation, and I'm going to balance this knee. And this takes some tinkering, right? And there's some high level, joint replacement principles that you have to adhere to in terms of how much bone you're resecting and where and all of this. So it's pretty technical, but you'll just watch as I start tinkering with this, we're going to end up in a much better place, okay? And each thing I change, you see it changing a little bit, and then I may decide to change one thing and say, no, that's not where I want to end up, and we'll change something else. So I can change our tibia there, put us in a little bit of valgus, because this knee started out valgus, the ligaments were already stretched. If we put it in perfectly straight, this patient's not going to be happy. So I'll change, add a little bit of valgus into the system, and what I want to end up doing is driving as close as I can to have a tighter medial side. Now, in a real bad valgus knee, where the medial side is so stretched out, I may not be able to have as much of a gap as I wanted. So here, I'm actually pretty happy with this, okay? I'd love for the medial side to be just a little bit tighter in extension, but with a valgus knee, unless I want to put this knee in crooked, I sometimes just can't do that, okay? So where we end up with here, I'm really happy with. Now, if you notice, On the lateral side, we're basically 0 in extension and we're 1.3 in flexion. You may say, well, why are you planting this knee so tight in extension? And the reason is, if you look at our flexion range, we actually have a real we have a hyperextension deformity in this knee. So this knee goes past 0, and this patient hyperextends their knee. I don't want to leave them like that. That's bad mechanics for a knee replacement. So we're going to plan the knee to be a little bit tighter in extension than in flexion. We'll take a little bit less bone off the distal femur, and that will correct that flexion, that hyperextension deformity. So that's the subtleties of things we're able to do with this robotic technology and plan for such incredible precision. So this is a plan for a valgus knee that's going to end up being a great result. So from here, what we do is go and execute our plan, and we can show you that in another video.